So then in this section, I'm going to talk to you about how to interpret the rate, rhythm, and axis. Now you'll recall, if you've seen the video on the 10-step system to interpret an ECG, before you even do this, you've got to look at the indications and the demographics. Why are you doing this ECG? Who are you doing it on? Once you've done that, that's actually the time to pick up the piece of paper or look at this ECG on your screen and ask yourself what the rate, the rhythm, and axis are. And that's very easy. If you look at the ECG and it's regular, to calculate the rate, what you do is you look at the number of large squares between two QRS complexes. So if there's 500 large squares, it's 300 over the number of large squares between two QRS complexes, and that gives you the answer of 60 beats a minute. If it's irregular, you look at the number of complexes in 30 large squares, which is 6 seconds, and multiply that by 10. You can do all of that, but actually there's a much easier way, and this is the way I use. I simply look at the ECG heart rate at the top left of the tracing. So I've said to you before, do not read the automated report, but actually the heart rate, rather than sitting there counting large squares, the simplest and most effective way, and dare I say probably the most accurate way of doing it, is simply looking at the automated readout that the ECG machine provides you. And it's not just the heart rate, the intervals, the PR interval, the QRS duration, all of that. You should actually preferentially look at the ECG readout. It's highly likely that will be more accurate than your eyes and your ruler. In terms of rate, we've explained that to you. In terms of rhythm, the key thing to identify is, have you got someone with a regular or an irregular rhythm? And the main reason as a healthcare system that we decided to move ECG acquisition and interpretation into primary care was actually to make sure that we detected atrial fibrillation early. In days gone by, and days certainly in my career, prior to this move, what we had was patients with irregular pulses being referred to hospitals for ECGs. That appointment could have been delayed for at least 2 or 3 days, if not a week. The ECG then had to be looked at by a cardiologist. The cardiologist then had to interpret the ECG, and that had to be relayed back to the primary care practice. And you can imagine all those steps, it could easily be several weeks before a patient with atrial fibrillation landed up having that diagnosis confirmed on an ECG. And that's more than enough time for them to develop a clot in the left atrial appendage and have a life-ending or certainly life-changing stroke, which is clearly something we all want to avoid. So ECGs in primary care, the main reason we went with this strategy was to make sure that we could figure out whether the rhythm was atrial fibrillation or sinus rhythm. Was it regular or irregular? And in this slide, you'll see a classic trace of sinus rhythm with electrical impulse started at the sinoatrial node. There is then a pause at the AV node as the ventricles fill, and then the electrical current goes down the left and right bundle branch block, causing ventricular contraction. So that's what we see in classic sinus rhythm. And what we want to ask ourselves when we look at the ECG is it regular or not? And sometimes it's actually quite difficult to say this, because you may have tiny P waves that you can't see. You might think that you can see P waves, but it doesn't quite look regular. And there is a well-proven system which doesn't rely on any form of ECG automation. It doesn't rely on AI. What you do is you take a piece of paper, you mark 3 dots in 3 contiguous QRS complexes, and then you move that piece of paper right along, slide it along at least 4 or 5 complexes and see if they still match. And that tells you whether the ECG is regular or not. Obviously, if you have someone with atrial fibrillation, what you're looking for is the absence of P waves and an irregular pulse. Now, in terms of axis, what is an axis? So in reality, it's something that when I ask people, what do you understand by the term axis? And certainly as a junior doctor, I interpreted many ECGs, talked about the axis without having a clue what axis actually meant. Axis is the overall direction of electrical travel within the heart, and the normal direction is from the top of the heart to the apex of the heart. Now, to interpret the axis, you just got to look at leads of the ECG. Which leads do you use? I'll take you through that. And what I'm showing you here on this big yellow arrow on this slide is the generalized direction of travel. That's what we call a normal axis. Now, I've shown you here on the left what looks like a pie chart and various vectors. I'm going to ask you to ignore that because there's a much simpler way of looking and interpreting what the axis is. And what you've got to do is look at leads 1 and 2 on your ECG, and very conveniently they are placed on the top left of the ECG. And you ask yourself two questions. Is the QRS complex in leads 1 and leads 2, are they pointing upwards? And if they're both pointing upwards, that's what we call a normal axis. If you then look at the ECG again, at another ECG, and you find that the QRS complex in lead 1 is pointing upwards, the QRS complex in lead 2 is pointing downwards, so they're effectively leaving each other, label that as left axis deviation. So left axis deviation, you have the QRS complex in lead 1 pointing upwards, the QRS complex in lead 2 pointing downwards, they're leaving each other. That's left axis deviation. The third pattern you may see is the QRS complex in lead 1 pointing downwards, the QRS complex in lead 2 pointing upwards, so they're reaching towards each other, and that's right axis deviation. So that's how you determine what the axis is. Don't worry about calculating vectors and things like that because you haven't got the time and it's completely unnecessary. And you can do that in leads 1 and 2 or in 1 and AVF. I would strongly recommend 1 and 2 because they're just next to each other, and certainly being in the having the mindset of an interventional cardiologist, you want to do the simplest thing possible. So here on this slide, there's a big clue on the screen as to what the axis is. This is someone with left axis deviation. We say that because if you look at the ECG complex, in lead 1, it's pointing upwards, and lead 2, it's pointing downwards. They're leaving each other, and it applies the same in lead AVF. So the key question is, what are the causes of left axis deviation? Now, in a 70-year-old individual, left axis deviation would almost be considered normal. So certainly in a 70-year-old, I wouldn't label this as an abnormality. Conversely, in a 25-year-old, if you've got left axis deviation, that's an abnormal finding and merits further and careful review and probably specialist review. In general, it's fair to say that as you get older, your axis, unlike your political affiliations, shift towards the left. And conversely, when you're younger, your axis is more rightwards, again, opposite to your typical political affiliations. So the causes of a left axis deviation can be summarized as normal, and that's really more age-related. You see it in patients with left ventricular hypertrophy or in a form of atrial septal defect. There is one thing that I would unfortunately need you to rote learn, as in memorize. If you see left axis deviation in the context of any form of block, be that first degree heart block, left bundle branch block, right bundle branch block, please call that left axis deviation left anterior hemiblock. And there is a particular case that we'll present as part of our ECG nugget videos that demonstrates the importance of this. So if you see left axis deviation in the context of any form of block, be that first degree heart block, second degree heart block, third degree heart block, left bundle branch block, right bundle branch block, please label that as left anterior hemiblock, and the relevance of that becomes clear in one of our later videos. Right axis deviation, so here on this slide, demonstration of that. The QRS complex is down in in lead 1, up in lead 2, and also in AVF if you prefer to look there. Causes of right axis deviation are once more age-related, but you do see it in patients with cor pulmonale and secondum ASD, and really any form of kind of right-sided congenital heart disease. The most common cause of right axis deviation in primary care will be in your young patients, but also in your patients who have got COPD and cor pulmonale. Now, on the top right of this slide, there's something very interesting. I've circled what's called the QRS axis. And another very neat way of figuring out what the axis is quickly is to remember two numbers. One is the number minus 30 degrees, 2 is the number plus 90 degrees, because anything that is more negative than minus 30 degrees would be considered left axis deviation. Anything that is more positive than 90 degrees would be considered right axis deviation. So here you've got someone whose QRS axis is 126 degrees. That's more positive than 90 degrees, so that's right axis deviation. If that number had been minus 40 degrees, that would be more negative than minus 30, that would be left axis deviation. So especially if you're not sure whether it's kind of on the borderline, just look at the number for the QRS axis, which is a helpful number that comes on the top of the automated ECG interpretation. And if it's more negative than minus 30, it's left axis deviation. If it's more positive than plus 90, it's right axis deviation. But leads 1 and 2 is really what you need to be looking at, and more often than not, you'll get your answer straight away. So in this ECG, the question is, what is the axis? In lead 1, the QRS is up. In lead 2, the QRS is up, so they're both facing upwards. So in my mind, this is entirely normal, and this is a normal axis. The question on this ECG is, what is the axis here? So let's look at it together. Lead 1, the QRS, is it up or down? It's clearly facing down. In lead 2, is it up or down? It's clearly facing up, so the two QRSs are reaching towards each other. This is right axis deviation, as you may find in anyone with who's young or potentially who's got right-sided heart disease due to cor pulmonale or the other causes I've already mentioned. Now the question here is, what's the axis on this ECG? So here the QRS in lead 1 is pointing downwards, the QRS in lead 2 is pointing upwards. So in fact, apologies, the QRS in lead 1 is pointing downwards, the QRS in lead 2 is also pointing downwards. So that doesn't really fit with anything. So normal is both QRSs pointing upwards in 1 and 2. Left axis, QRS in lead 1, QRS 2 are leaving each other. Right axis, QRS in lead 1, QRS in lead 2 are reaching towards each other. Here, they're both pointing downwards. Now, my tip to you is, if you see that happen, the next lead you need to look at is AVR. Because you've got here an indeterminate axis. So if you see that, and you will see that, I'd say early on when I used to field interpretations for GPs, I'd see this at least once a week from ECG sent in, and I'd always look at AVR. And the reason to look at AVR is, in AVR, the electricity is going away from the heart, and actually all parts of the QRS complex in AVR should be downwards, because it's going the opposite direction to the heart. So your P wave, your QRS, and your T wave should all be downwards. Now what happens is, if you see an indeterminate axis with any part of AVR pointing upwards, you've got to suggest, the suggestion here is that the leads have been misplaced. So that pattern of an indeterminate axis where the QRS points downwards in 1, downwards in 2, but actually in AVR you've got an upward QRS complex, that pattern tells me and would inform you that unfortunately the ECG leads have been misplaced, typically a left-right misplacement. So that's the pattern you see, indeterminate axis, and the diagnosis unfortunately of a misplaced ECG. So if that's happening, misplaced leads, if that's happening, repeat the ECG and potentially ensure that whoever's taking the responsible for the ECG acquisition has been trained appropriately to place the leads.